Okay. Good evening, everyone. I am Ahmed Awida, third year resident, Main Hospital, Alexandria University. I am today going to talk about optic nerve diseases, episode 1. So we have a lot of optic nerve diseases. We have the optic atrophy, optic neuropathy, papilledema, and congenital anomalies of the optic nerve. Today we are going to talk about the first two topics in red, optic atrophy and the optic neuropathy. So let's start. Here, I can show you the 4 types of optic atrophy. Here we have the primary optic atrophy, the secondary optic atrophy, the consecutive optic atrophy, and last but not least, the glaucomatous optic atrophy. Do you see the cursor on the screen?
Yes, we do.
Yes.
Perfect. We will start with the primary optic atrophy. Simply, primary optic atrophy means it's atrophy of the optic nerve due to diseases that didn't cause disc edema. It's not preceded by swelling of the optic nerve head or the optic disc. Such diseases can be compressive tumors, can be demyelinating optic neuritis, any disease that can cause affection of the optic nerve without disc edema resulting into optic atrophy. This is called primary optic atrophy. And as we can see here in the picture, it will be a flat, chalky white with distinct margins. Sometimes we might have some attenuated small vessels over the disc. Unlike the secondary optic atrophy, as we see here, it is preceded by a long-standing swelling of the optic nerve head or the optic disc. So any disease that can cause edema of the disc and eventually resulting into an optic atrophy, this is called secondary optic atrophy, such as papilledema, which is usually a bilateral condition characterized by disc edema secondary to increased intracranial pressure, GCA, giant cell arteritis, that can cause anterior ischemic optic neuropathy resulting into disc edema, eventually ending with optic atrophy, and other causes of optic neuropathy that can result into disc edema, eventually will end up with a secondary optic atrophy. It has a very characteristic appearance, as we see here. The edges of the disc are blurred, and there is some gliosis over the disc, and very characteristic chorioretinal folds concentric around the disc called pattern lines, which are chorioretinal folds surrounding the disc, very characteristic of secondary optic atrophy. Third, we have the consecutive, not the tertiary, it's the consecutive optic atrophy, which is atrophy of the optic nerve head secondary to a retinal disease. As you can see here, we have a fundus picture showing retinitis pigmentosa, pigmentary changes in the periphery of the retina, resulting into optic atrophy. This kind of optic atrophy is called consecutive. This is wrong, it's not tertiary, it's consecutive optic atrophy. So any retinal disease, which is usually obvious in our fundus examination, that result into optic atrophy, this is called consecutive optic atrophy, and in which the optic disc or the optic nerve head has a characteristic waxy appearance. Last but not least, we have the glaucomatous optic atrophy, which is an optic neuropathy secondary to glaucoma. As we all know, glaucoma is a progressive optic neuropathy, which is characterized by visual field changes and optic nerve head changes plus or minus increased IOP. Very characteristic, as we see here in the picture shown in our slides. Here on the right, we have a normal sized cup in a normal sized disc. On the other side, we have increased cupping of the optic disc and attenuation of the neuroretinal rim. This is called cupping, and this is very characteristic of glaucoma. we have to mention the 4 classical types of glucomatous optic disc. First, we start with the focal ischemic type, in which we can see here an inferior notching. Secondly, we have the sclerotic type with a superior notching. Here we have the myopic type and very characteristic myopic fundus and myopic disc with the peripapillary atrophy, as you see here. And lastly, we have the concentrically enlarged cup, deep uniform cup, as you see here. These are the 4 classical types or morphological appearances of the glucomatous optic disc. Now let's discuss the second topic with us, which is the optic neuropathy. We have etiological classification of the optic neuropathy, starting with the inflammatory causes, which is called optic neuritis, including the demyelinating, the para-infectious, infectious, and so on. We have the glucomatous. We have the ischemic type, we either anterior or posterior ischemic optic neuropathy. We have the hereditary causes with positive family history. We have the nutritional and toxic causes, as we see a lot in our toxicology department with methanol toxicity and so on. We have the papilledema that, as I mentioned before, can cause secondary optic atrophy. We have the traumatic causes, as my colleague Haitham mentioned in his trauma lecture. We have the compressive and infiltrative causes. Today, I am gonna discuss the items in red, as the other items will be discussed in the specific lectures related to. Let's start with the inflammatory optic neuritis. We can divide the inflammatory causes of optic neuropathy, or what's called optic neuritis, according to the ophthalmic appearance or according to the etiology. According to the ophthalmic appearance, we can have a retropalpar neuritis, as you see, in which the optic nerve head or the optic disc looks healthy, normal. Or we can have papillitis, in which, as we see here, the optic disc is swollen, edematous, sometimes with splinter hemorrhages and so on. And we can have what's called neuroretinitis, neuro related to the optic disc, which will be edematous and swollen, and retinitis related to the retinal affection, particularly the macula, with a very characteristic appearance called macular star. And this is very characteristic of neuroretinitis. And I think, as we all know, the most common cause of neuroretinitis is cat scratch disease. 60% of cases of neuroretinitis is caused by the cat scratch disease. 25% idiopathic, and the remainder related to the other causes like Lyme disease and sarcoidosis and so on. This is the ophthalmic appearance classification of optic neuritis or inflammatory optic neuropathy. The second classification, according to the etiology, is it demyelinating, in which we have the most common cause multiple sclerosis, MS, non-infectious like sarcoidosis, para-infectious following immunization, infectious like cat scratch disease, which I have mentioned a few seconds ago, the major cause of neuroretinitis. Let's start with the demyelinating disease. Our nerves in the CNS and the BNS is surrounded by a sheath called myelin sheath, which is responsible for proper conduction of our nerve impulses. Sometimes in certain disorders or other autoimmune diseases, we might lose this myelin sheath, phagocytosed by microglial cells and macrophages. And the loss of this myelin sheath can cause problems in conduction of our nerve impulses. We have 4 categories of demyelinating diseases. We can have an isolated optic neuritis affecting only the optic nerve, or we have the most common cause of demyelinating disease, which is the MS. We can have Devic disease, which is called neuromyelitis optica. Neuro related to our optic nerve, myelitis due to affection of the spinal cord, optica. And we have shoulder disease, which is a very rare disease, progressive generalized disease, actually affecting children prior to the age of 10 years, with a death, unfortunately, within 1 to 2 years. So let's start with our most common cause of demyelination, MS. MS can affect multiple systems in our body, and it is an idiopathic cause of demyelination of central nervous system white matter. So it's a disease of the white matter, and it's a disease of the CNS. Can affect or can have systemic manifestations, can affect the spinal cord, causing dysphagia, dysarthria, can affect the cerebral hemispheres, causing dysphasia, can have some transient manifestations, a phenomena called Youth's phenomena, in which there is worsening of visual symptoms or other manifestations upon exercise or increase in body temperature. And we have what's concerns us here, which is the ophthalmic features. The most common is the optic neuritis, which is usually retrobulbar. As I've mentioned, one of the ophthalmic classification is the retropulbar neuritis, in which the appearance of the optic disc is normal at first. Maybe weeks later, optic atrophy can happen. Other common ophthalmic manifestations, including INO, nystagmus, uncommon manifestations like skew deviation, ocular motor neuropulses, hemanopia. For those who doesn't know what skew deviation is a vertical motility disorder that is not assigned to a certain muscle or nerve palsy. This is what's called skew deviation, which we study in Squint chapter. And rarely, MS can cause intermediate uveitis, manifested as vitritis and retinal purifications. What investigations can be done to diagnose MS? We have what's called lumbar puncture, which will show oligoclonal bands on protein electrophoresis in 90 to 95% of the cases. MRI, very important to put in mind neuroimaging in cases of MS or suspecting MS. Very characteristic, without saying it's a periventricular white plaques. This is a very characteristic sign in the MRI in cases of MS. Also, we have visual evoked potentials, which are usually abnormal. As I've mentioned, it's a demyelinating disease. We lost our myelin sheath. Our conduction will be delayed. This slide is, in my opinion, the most important slide in my presentation. What are the associations between the optic neuritis and multiple sclerosis? Very important. Any case presenting with demyelinating optic neuritis, I will mention in the next slides. What should I do, or what percentage of such individuals can develop MS? If you didn't do an MRI, 50% of the cases who develop demyelinating optic neuritis will develop MS in the next 15 years. If you did an MRI and it was free, it decreases to 25%. And if you did MRI and it showed lesions, it will rise into 70%. So very important to properly diagnose optic neuritis and to do MRI and to counsel the patient about the risk of MS. MS is not considered a hereditary disease, but however, there are some associations with HLA, GR15, and DQ6. The sentences I marked red, very important, because sometimes we might have a condition of optic neuritis, demyelinating optic neuritis, but we usually don't start the immunomodulatory MS prophylactic treatment because the signs or the manifestations in these patients are not typical. As we see, it is a male gender, absence of viral syndrome preceding the optic neuritis, optic disc swelling, vision reduced to no BL, absence of periocular pain. Remember these items because these items are usually against the typical demyelinating optic neuritis. Demyelinating optic neuritis are usually in females with preceded viral syndrome, and it's usually retrobulbar. There is no disc swelling, and vision ranging between 660 and 612 with the presence of periocular pain. So these red items are against the typical criteria for demyelinating optic neuritis, so that we usually don't order immunomodulatory MS prophylactic treatment. Optic neuritis is the presenting feature, of course, in case of MS in 30% of the cases. And at some point, our MS patients will develop optic neuritis in 50% of them. This is very important slide also, the clinical features of demyelinating optic neuritis. Usually, there is subacute monocular visual impairment. The average age is 30, between 20 and 50. There is discomfort or pain in or around the eye, 90% of the patients, and typically exacerbated by ocular movements. We have sometimes frontal headache and tenderness. Signs, visual acuity, 618 to 660, sometimes maybe worse. Other signs including the bird color vision, the relative afferent pupillary defect, which are the signs of optic nerve dysfunction. Optic disc is normal in the majority of patients. I'm repeating, the typical demyelinating optic neuritis occurring in females, young age, with pain in or around the eye, and it's usually retrobulbar. Usually, the optic disc appearance is normal. Sometimes when we examine the other eye, we might find a temporal disc pallor, which indicate a previous attack of optic neuritis in that eye. Visual field defects, diffuse depression of sensitivity in the entire central 30 degree is the most common type of visual field defects we encounter in demyelinating optic neuritis. However, in some cases, we might encounter altitudinal visual field defect, nerve fiber layer visual field defect, or centrocecal paracentral visual field defect. But this is the most common visual field defect we encounter in demyelinating optic neuritis, the generalized depression of the central 30 degrees of our visual field. The course, very characteristic, and remember with me, demyelinating optic neuritis, there is worsening over several days to 3 weeks. Later on, the recovery starts to occur spontaneously, but more or less, it's fairly slow over the next 6 to 12 months. Prognosis, more than 90% recover to 6-9 or better, yes, without treatment. Around 10% can develop chronic optic neuritis with slowly progressive or stepwise visual loss. We might encounter the persistence of mild REBD in the recovered patients with some temporal optic disc pallor. Let's go to the second etiology of optic neuritis or inflammatory optic neuropathy, which is the para-infectious following viral infections or immunization. Children, usually affecting children 1 to 3 weeks after viral infection or immunization. And as I put in red, the rule is bilateral papillitis. So it's a bilateral disease, unlike the demyelinating optic neuritis, which is usually unilateral. And it's a papillitis. So there is disc edema and swelling, unlike the demyelinating, which was retrobulbar neuritis. Prognosis is good. Spontaneous visual recovery with no treatment is required. What about the infectious causes? We have the sinus-related recurrent attacks of unilateral visual loss. We have cat scratch disease. I've mentioned before, it's the most common cause of neuroretinitis. Syphilis can cause acute papillitis or neuroretinitis. Lyme disease can cause neuroretinitis or occasionally acute retrobulbar neuritis. Cryptococcal meningitis in patients with AIDS can be associated with bilateral optic neuritis. Varicella zoster virus can cause papillitis from contagious. It's a very common cause of acute retinal necrosis, and this lesion can spread to the disc, causing papillitis, or in association with the herpes zoster ophthalmicus. And lastly, the non-infectious causes. I'm showing you a Faun's picture of a sarcoid patient, and the arrow in blue shows us the lumpy appearance, which is suggestive of granulomatous infiltration. This is very characteristic in sarcoid patients. Optic neuritis affecting 1 to 5% of these patients with neurosarcoidosis, and they respond well to steroids, systemic steroids. We have finished now the inflammatory cause of optic neuritis, optic neuropathy, optic neuritis. Now we will discuss the ischemic causes of optic neuropathy. But before discussing the ischemia, let's find out what's the blood supply of the optic nerve. As we see here, we have the optic nerve coming out from the globe. It is supplied the optic nerve head, the optic disc. As you see here, it's supplied by the peripapillary choroidal arteries, circle of Zenith, and short posterior ciliary arteries. And along its length, it's supplied by the central retinal artery and pile vasculature, pile plexus from the ophthalmic artery. This is the blood supply of the optic nerve. If the ischemia affecting the blood vessels that supply the optic nerve head, it will result into an anterior ischemic optic neuropathy, whether arthritic or non-arthritic. If the ischemia affecting the blood supply of the posterior segment or retrolaminar portion of the optic nerve, this will result into posterior ischemic optic neuropathy. So the ischemic optic neuropathy is divided into three types: non-arthritic and arthritic causes of anterior ischemic optic neuropathy and the posterior ischemic optic neuropathy. Let's start with the most common of which is the non-arthritic type. Non-arthritic anterior ischemic optic neuropathy, we have a list of risk factors. Please memorize these risk factors, because when we attack these risk factors, we can control our disease. We have one of the risk factors, the structural crowding of the optic nerve head, hypermetropic patients, hypertension, very common, diabetes, hyperlipidemia, collagen vascular disease, antiphospholipid antibody syndrome, hyperhomocystinemia, sudden hypotensive events. This is very important cause also of posterior optic neuropathy. And cataract surgery, yes, I have encountered one or two cases of cataract surgery that is complicated. They are complicated by non-arthritic anterior ischemic optic neuropathy, and the patient lost his vision. He went into the OR for cataract removal and improving his visual acuity, and suddenly he lost his vision permanently. Unfortunately, yes. Symptoms. Our patients here usually complain of sudden, painless monocular visual loss. So it's sudden, it's not a subacute, and it's painless unilateral or monocular visual loss signs. Visual acuity is normal or only slightly reduced in about 30% of the cases. The remainder, there is marked or moderate to marked affection of the visual acuity. Visual field defects are typically inferior altitudinal. I have shown you before how the optic nerve affection can cause a lot or many types or patterns of visual field affection. Can be central, paracentral, arcuate, but it's usually here inferior altitudinal. Very important, what I have put in red. This chromatopsia or the color vision affection is usually proportional to the level of the visual impairment. Why I have put this in red? Because unlike optic neuritis, here we have both the visual acuity and the color vision affection proportional. But in optic neuritis, the color vision is more or markedly affected in comparison to the visual acuity. Sometimes you might have the patient coming with color vision affection before visual acuity affection. Diffuse or tectural hyperemic disc swelling, yes, this is anterior ischemic optic neuropathy. So the optic disc abnormality. Please, can you mute Sam? Please, can you mute your microphone? Or I will be forced to mute all of you. Okay. Let's continue. As it's an anterior ischemic optic neuropathy, so we have a diffuse or sectoral hyperemic disc swelling, often associated with peripapillary sphincter hemorrhages. And as all our disc swelling, it will gradually resolve and results in disc pallor. And in which type, if you can answer me, which type of optic atrophy we will encounter in this patient? Can anyone answer me?
Primary.
Perfect. It's a primary. No, it's not a primary. It's a secondary optic atrophy. Because in these patients, we have disc swelling. these patients having anterior ischemic optic neuropathy. So there will be a disc swelling, and this disc swelling, when it resolves, it will result into secondary optic atrophy. Secondary optic atrophy is optic atrophy preceded by long-standing disc edema. So here, these patients will have secondary optic atrophy, not primary optic atrophy. Investigations include the assessment of the risk factors I have mentioned before. We need to control these risk factors. Prognosis, there is improvement in vision in common cases. About 50% of these eyes will achieve 6/9 or better, though 25% will unfortunately reach only 6/60 or worse. The fellow eye. This is very important. In 10% of our patients, after 2 years, they will develop affection of the other eye, and in 15% after 5 years. Treatment. There is no definite treatment. We only targeted to attack the risk factors and control them. Some authorities may suggest the short-term use of systemic corticosteroid therapy, but no evidence-based efficiency of this regimen, the systemic steroids. Second, we have the arthritic anterior ischemic optic neuropathy. Before discussing this type of optic neuropathy, we need to discuss a very important sight-threatening condition, which is called GCA, giant cell arthritis. It's a granulomatous necrotizing arthritis with a predilection for the large medium-sized arteries. It usually attacks what I have put in red, the elastic tissue in the median and tissue of the blood vessels, like the superficial temporal artery, ophthalmic artery, aortic branches. But usually the intracranial vessels are spared because of the low content of the elastic tissues. Smoking, low body mass index, early menopause, independent risk factors, patients are usually elderly. It's very, very, very rare, extremely rare before the age of 50. GCA is a disease of the elderly, above the age of 60, around 70. And here, women are affected 4 times more commonly than men. So we have the demyelinating disease, or the MS, in which the females to male ratio is 2:1. And here with the GCA, we have a female to male ratio 4:1. These patients usually present with the following: scalp tenderness because of the affection of the arteries of the scalp, first noticed when combing the hair. Headache, could be frontal, could be occipital, temporal, or maybe generalized. And very important here, the cramp-like pain on chewing, the jaw claudications. This is very pathognomonic of GCA, caused by the ischemia of the masseter muscles. There are some non-specific symptoms such as weight loss, fever, night sweats, malaise, depression, double vision, and I will discuss this with you later in the following slides, the arthritic anterior ischemic optic neuropathy. Other features: superficial temporal arthritis characterized by the artery itself is thickened. This is inflammation, thickened, tender, inflamed, nodular arteries. Those signs may be sometimes subtle. Pulsations. It is unusual not to have pulsations in normal individuals. So in cases of GCA, we will have lost pulsations, non-pulsatile superficial temporal artery. This is very uncommon in the healthy individuals. So when you try to pulsate the superficial temporal artery and you don't find pulsations in your patient, suspect GCA. We might find ocular motor palsies, pupil involving third palsy, scalp gangrene can occur in severe cases. Rare complications of GCA, including dissecting aneurysms, aortic incompetence, myocardial infarction, renal failure, and brainstem stroke. We have the American College of Rheumatology, which have set some criteria to help us diagnose the GCA. First, the ESR should be at least above 60. CRB, no, sorry, this is not the American College of Rheumatology criteria. I will mention these investigations and I will enumerate with you the American College of Rheumatology criteria. which we see here. These are the investigations that we can do in patients with GCE or suspect GCE, like ASR, it will be high for sure, CRP, full blood count, we will find elevated platelets with normocytic pneumochronic anemia. Liver function will be abnormal in 1/3 of the patients. Autoantibodies are normal. This is not an autoimmune disease. Temporal artery biopsy. This is very important in cases of GCA. Before explaining the or discussing the temporal artery biopsy, I will enumerate to you the American College of Rheumatology criteria for diagnosing GCA. These are 5 criteria. ESR of 50 at least, age of onset of 50 years old, new headache, temporal tenderness, and temporal artery biopsy showing vasculitis and infiltration by multinucleated giant cells. These are the 5 criteria for diagnosing GCE according to the American College of Rheumatology. High ESR, at least 50, age, at least 50, new headache, temporal tenderness, and temporal artery biopsy, positive. How can we obtain a biopsy from the temporal artery? Ideally, be performed within 3 days of commencing steroids, at least. And let's be careful about this point. At least 2.5 centimeters of artery should be collected with the serial sections. Why? Because of a phenomena common in GCE, which is called skip phenomena, in which the disease skip areas or regions of the artery normal. So if you took only one biopsy or one sample, you might take it from the normal segment of the artery and misdiagnose or miss the condition. So we need to take at least 2.5 centimeter and serial sections. If there is ocular involvement, take the biopsy from the ipsilateral side. And in red, a negative tab should not prevent ongoing treatment in the presence of convincing clinical picture of GCE. Why? Because 15% of GCE patients have normal histopathology. So once you suspect GCE with your clinical findings, start systemic steroids, as I will mention later. Here is a biopsy taken from temporal artery in a patient with GCE. There is transmural infiltration. There is disruption of the internal elastic lamina. And as you see here, narrowing of the lumen. Here is a color Doppler, duplex ultrasound of the femoral artery showing the characteristic hypoechoic halo. As you see here, this is a hypoechoic halo around the femoral artery denoting edema in the wall of the artery denoting inflammation vasculitis. What about the arthritic anterior ischemic optic neuropathy? It's not just GCA, it is GCA that affects the artery supplying the optic nerve, causing the arthritic anterior ischemic optic neuropathy. Symptoms is a sudden profound unilateral visual loss with periocular pain, and the manifestations, as I have mentioned, of the GCA. We need to know something very important. If we didn't treat GCA, 30 to 50% of patients will develop arthritic anterior ischemic optic neuropathy. And if we left this condition untreated, within a week, the other eye will be affected. And the patient will end eventually with blindness. As you see here, simultaneous bilateral involvement is rare, but rapid involvement of the second eye, very rapid, maybe within a week, can affect the other eye and result into total blindness. As I will mention later, when we treat GCA, and especially if it caused arthritic anterior ischemic neuropathy, we are not trying to rescue the affected eye, no. Most probably the vision in this eye will be lost forever. We are trying to save the fellow eye from being affected. I will mention this, but keep in mind. Signs severe visual loss is the rule, of course. However, the upper and lower circulation can be affected, leading to alternating visual field effects. The disc appearance is pale, chalky white, edematous disc, particularly suggestive of GCA, and over 1 to 2 months, it will eventually end with optic atrophy, which is secondary optic atrophy. I'm talking about anterior disease that affected the optic nerve head. So it will end up with disc edema and secondary optic atrophy. Prognosis is very poor. Visual loss is usually permanent. Yes. GCE that caused anterior ischemic optic neuropathy, it will result into blindness in this eye. In most of the cases, we are trying, our aim is to preventing blindness of the fellow eye. The second eye. Here is a very sad fact that even if you started your treatment earlier, the other eye will be affected in 25% of the cases, despite of the early intervention and treatment. What is the treatment of GCE that caused arthritic anterior ischemic optic neuropathy, and what is the treatment of GCE without affecting or without causing arthritic anterior ischemic optic neuropathy? GCE alone, no affection of the optic nerves, there is no visual involvement. GCE is treated by oral prednisolone, 1 to 2 milligram per kg per day. If there is affection of the optic nerve, we will start aggressively with intravenous methylprednisolone, 0.5 to 1 gram per day for 3 consecutive days, followed by oral prednisolone, 1 to 2 milligram per kg per day for 3 days. And we can reduce the dose to 50 to 60 milligram, that is not less than 0.75 milligram per kg for 4 weeks. Until our symptoms resolve, ESR and CRP is normalized, then we can taper gradually by reducing the dose every 2 weeks, 10 milligram per kg, till reaching a maintenance dose of 20 milligram per kg. Very important, and something we usually miss during management of not only the optic neuropathy cases, but other cases that require systemic steroids, the side effects of the systemic corticosteroids. We need to put in mind bone protection and GI protection. Bone protection by calcium and vitamin D supplementation, and GI protection by proton pump inhibitors. Other therapies, including the antiplatelet therapy, aspirin, can reduce the risk of visual loss and stroke. Any significant symptomatic relapse should be treated with an aggressive increase in the steroid dose. In patients with steroid-resistant cases or steroid sparing, we can use immunosuppressive regimens as methotrexate and so on. Biological blockers have not shown to be effective in such cases. Pseudo-Foster-Kennedy syndrome. What is this? Does any one of you know what is the Foster-Kennedy syndrome? Anyone?
هو تقريبا bilateral هو optic disc edema due to frontal lobe tumor I think.
هي بيبقى فيها اوبتيك ديسك اديما والثانيه بيبقى فيها اوبتيك اتروفي.
Perfect. Yes. Foster-Kennedy syndrome is a condition characterized by a frontal lobe space occupying lesion that compressing the optic nerve on one side, causing optic atrophy, and increasing the intracranial pressure, causing optic disc edema on the other side. As these two pictures, we have on one side the optic atrophy, and on the other side we have the optic disc edema. This, from the first look, you can say this is a Foster-Kennedy syndrome, but it's actually a pseudo Foster-Kennedy syndrome. This actually started, this condition or this patient started with an attack of anterior ischemic optic neuropathy in this eye that resulted into secondary optic atrophy. And later on, weeks, months, or years after that, the other eye attacked by anterior ischemic optic neuropathy, which is presented by a disc edema. At this stage, we can call this pseudo Foster-Kennedy syndrome. What about the posterior ischemic optic neuropathy? This is much less common than the anterior variety. As I mentioned before, it's caused by ischemia of the retrolaminar portion, which is supplied by the pile capillary plexus, and we shouldn't diagnose PION except after exclusion of other causes of retrobulbar optic neuropathy. What are the 3 causes of posterior ischemic optic neuropathy? Operative, arthritic, or non-arthritic. Arthritic or non-arthritic as the ion. The operative causes is surgeries. that require hypovolemic hypotension or hypovolemia, that some surgeons ask the anesthesia for hypovolemia or hypoperfusion. They need bloodless field. So anesthesia tries to, as much as possible, to provide the surgeon with a bloodless field and at the same time saving the vital organs. In my second year of residency, I have encountered a patient. He was seeing 6-6 pre-op. He had spinal surgery. He went into the OR with a sheet from our department. He sees 6-6 OU. And after finishing his surgery, he came out from the OR, no BL in both eyes. He lost his vision for life. What is this? This is posterior ischemic optic neuropathy. What happened is the neuro surgery surgeons asked the anesthesia for a bloodless field, so they reduced the perfusion to the optic nerve. This caused posterior ischemic optic neuropathy, and the patient lost his vision. Very rare, but can happen. Also, a very rare complication of diabetes, something called diabetic papillopathy. This is considered a variant of iron occurring in young diabetics unrelated to the blood glucose level, in which the patient complains of mild, painless visual impairment. Sometimes the visual acuity may be normal or very slightly affected. And upon examining the disc, as it says, diabetic papillopathy, papillitis, there is disc edema, telangiectasia, as we see here, maybe sometimes splinter hemorrhages, as we see. Fortunately, spontaneous recovery can occur within months. No treatment is required. Other etiology of optic neuropathy, which is called Leber hereditary optic neuropathy. Simply, it's ganglion cell degeneration that typically, and very important focus with me here, affects the papillomacular bundle. Papillomacular bundle is responsible for the central vision. And that's why when I talk about the symptoms, I'm saying there is loss of the central vision, because it's a ganglion cell degeneration of the papillomacular bundle. It's a maternally inherited mitochondrial DNA. So it is usually almost affecting males. Mitochondrial DNA, mitochondria is inherited from the mother, so it's a male disease, usually between the age of 15 and 35. Symptoms occurs of acute severe painless unilateral visual loss of the central vision because the affection is in the papillomacular bundle. Signs color vision is likely to be abnormal, of course, REPD. There is disc hyperemia with the obscuration of the disc margins. Very characteristic sign in Leber hereditary optic neuropathy is the telangiectatic microangiopathy. Let's see together. These are the stages of the Leber hereditary optic neuropathy. The first image, as we see here, this is the acute stage in which there is disc edema. And later on, this is the characteristic sign I have told you about, the telangiectatic vessels, telangiectasia, and eventually optic atrophy. Can I ask again, what type of optic atrophy is this?
It's secondary.
Perfect. This is a secondary optic atrophy. Very small tip, undertake genetic testing. Of course, this is a hereditary disease, so we need to do a genetic testing and take very meticulous and careful family history. There is something called Leber hereditary optic neuropathy plus. Plus means we have the optic neuropathy in addition to neuromuscular dysfunction. Prognosis, unfortunately, is poor. OCT might show a peripapillary retina thinning, visual field defects, maybe central, maybe centrocecal scotomas, with a preserved peripheral vision. I have mentioned before, it is a disease of the papillomacular bundle, so the central vision is affected. So we have a preserved peripheral vision. Fluorescein angiography show a very characteristic sign, and it's a very common MCQ question. No leakage from the disc or microangiopathic vessels. There is no leakage. When we have an optic neuropathy with a fluorescein showing no disc leakage, this is most probably Leber hereditary optic neuropathy. Unlike other cause of optic neuropathy, we will find leakage from the optic disc. Of course, genetic testing because it is a hereditary disease. We have some miscellaneous hereditary conditions, what's called dominant optic atrophy. From its name, it's an autosomal dominant. Burr syndrome, it's autosomal recessive. Wolfram syndrome, or sometimes they call it DIDMOD. Diabetes insipidus, diabetes mellitus, optic atrophy, deafness. This is syndrome characterized by all these four criteria. Could be autosomal dominant, could be autosomal recessive, could be mitochondrial inherited. Let's keep in mind the first two have a good visual prognosis, and Wolfram with all these diseases have a very poor visual prognosis. In the picture here, we can, or I can show you, here we have temporal disc pallor only. This is the temporal disc, here and here, pallor. Here we have a diffuse pallor of the disc. The hereditary optic neuropathy can present with a temporal pallor only or a diffuse optic disc pallor. Nutritional optic neuropathy. It can cause by a deficient mitochondrial function. So the problem here is the mitochondrial function. This nutritional can be diet neglection or inadequate dietary intake. Diet neglection, like those in the Western countries who are alcoholics, don't care about their nutrition, there is diet neglection, or in Africa, poor African countries, there is inadequate dietary intake. However, be careful. Strict vegan diet can also be a causative factor for the nutritional optic neuropathy. So don't rush to the diet. And I want to be healthy and I want to be fit without being careful about the nutritional elements that you need to take. Symptoms: insidious. This is not acute or subacute. It's called, you can consider it subacute. It's not acute. Insidious onset of painless bilateral central blurring associated with abnormal color vision. Inquiry should be made about the potentially causative medication. Of course, we will discuss in the last slide about the toxic. We have what's called nutritional optic neuropathy, and we have what's called toxic optic neuropathy. A family history of optic neuropathy should be excluded for sure, because we have a bilateral disease, and hereditary optic neuropathy can be bilateral, so we need to exclude hereditary conditions. Science visual acuity is variably affected. The discs at presentation sometimes be normal, and later on can show some pallor. Pupil, you might think this is an optic neuropathy, so I have to find RAPD. No. In case of nutritional optic neuropathy, you might find pupil reactions to be normal. And in severe cases, you might find a weak response. Other ocular and systemic features of nutritional deficiencies should be sought, of course. Wernicke's disease, pernicious anemia, xerophthalmia, purpura should be considered in the developing nations. We are trying to look for the cause of this nutritional deficiency. Visual field effects are bilateral because it's a bilateral disease, relatively symmetrical for sure, centrocecus, scotomas. OCT might show peripapillary retinal fiber layer thickening, fundus, autofluorescence to help differentiate this nutritional toxic neuropathy from other macular diseases and rod-cone dystrophy. Prognosis is good, fortunately, provided that the patients receive the proper treatment, although, and as I put in red, visual recovery may be slow. Blood tests for sure for the vitamin B12, vitamin B1, 2, 3. We are, as I said before, looking for the cause of this nutritional deficiency. MRI is commonly considered if I find atypical presentation. Marked asymmetry, supposed to be symmetrical, as I've said here, for example, in the visual field effects. So if you find marked asymmetry, disc pallor, but good vision, we need to look for something else. We need to do neuroimaging. Treatment. There is dietary insufficiency, so we need to provide our patient with dietary revision of his nutritional elements. increasing fruit and leafy green vegetables intake. Abstention, of course, from alcohol and tobacco is very difficult in the Western countries, of course. We can provide him with vitamin E and other multivitamin preparations, intramuscular hydroxycobalamin injections. All we are trying is two things: avoid elements that can cause this optic neuropathy and providing the patient with the nutritional elements that he needs for healthy life. Of course, exposure to the identified agent should be discontinued. Lastly, we have toxic optic neuropathy. We have a group of toxins that can cause toxic optic neuropathy. Ethambutol, which is an anti-tuberculous drug. It's a dose and duration dependent. Toxicity typically occurs between 3 and 6 months of starting the treatment. Isoniazid, also for tuberculosis, the risk of toxicity increased when it's given in combination with the ethambutol. Amiodarone, antiarrhythmic drug, can cause demyelination, and this demyelination can cause the optic neuropathy. It's not dose related. Do you or does any one of you know what else can amiodarone do in the eye?
corneal degeneration اعتقد.
Vortex keratopathy.
Perfect. Yes. Vortex keratopathy. And what else? It does something to the lens. Do you know what type of cataract can cause, or what type of opacity can cause in the lens? Amiodarone.
Posterior subcapsular.
Bravo. Yes, it's a posterior subcapsular cataract or opacity. We have also vigabatrin. It's anti-epileptic drug. It can cause bilateral concentric, predominantly nasal visual field constriction. Methanol, homemade alcoholic beverages, as I have mentioned. A lot of our young patients coming to our toxicology department suffering from methanol toxicity. How does methanol selectively affect or attack the optic nerve? Is by forming what's called formic acid. Methanol in the body forms what's called formic acid. This formic acid have a very affinity characteristic effect to the optic nerve that can cause disruption of its neuronal conduction. And I have finished. Thank you.
Thank you.
Any questions? Reis, Haitham, any questions? يا جماعة حد سامعني؟
شكرا يا دكتور عويد، الله ينور يعني.
Thank you, Haitham. So I hope you enjoyed the lecture and meet you next week, inshallah. Good luck. Bye-bye.
Thank you. Good night.
Thank you. Good night, all.